Gotta be able to get, oh, there we go. Good.
That
Thanks,
way we
Larry.
can throw it on.
Yeah, no problem. Thank you. So we are going to talk about pathophysiology today, okay? And, pathophysiology is a whole semester plus course, and we're going to do it here in a few hours. And so it's going to be kind of the highlights, and it gives you hopefully a refresher on some base knowledge. We might learn a little bit new today, but I think the best part of this lecture today is going to be the slides that I put together for you. And basically what I did is I took the top reasons why readmissions occur. So I gathered that data, and what I did is I made slides for each one. And so we're going to talk about each illness that causes high rates of readmission. And so we'll go through all of that, and it's going to be kind of cool. I think that you'll see this. Now, that's aside from the reasons people would go utilize the ER. So I see, this community paramedic being the link for two key pieces in the community, and that would be availability of acute care, right? Like, hey, my CHF is exacerbating, I'm getting short of breath, and I'm up 15 pounds in the last 10 days, and I haven't done anything about it, as opposed to, hey, I just got discharged, I had a bad CHF exacerbation, and our goal is to keep, one of the goals on the acute side is to keep the patient from being admitted, and then on the discharge side, hospital discharge following side, it would be to keep the patient from going back in. So that's what kind of later on is going to be. We have one more person coming in here. All right. So we have now, let me get this straight. April, Amanda, Angela. All right, Angela, can you hear us?
Yep, I can hear you.
Okay, great. So this is going to be kind of a slide heavy. You can listen to the lecture, but you might want to go back and play it. This is Patrick, and you can watch it at your convenience. But today's pathophysiology, okay? And then once we get done with pathophysiology, you had the last week, the course was culture and how that plays into healthcare, and we'll talk about culture competence and what some of the things we might need to be aware of. And it's more of a self-awareness piece when we go into people's homes and work with them, more so than a real in-depth lecture on all of the different cultures. You guys probably realize that when you got into the chapter and read it. So let's get started. I'm going to use the agency or the textbook slides here to go over the textbook. We'll probably reference a few pages, Angela, in the textbook, but you don't need to. When you listen to this down the road, you can utilize the cues to look at the pictures in the book as we explain things. Okay.
Awesome, sounds great.
Yeah. Okay. Slideshow, please work. Do I have control, Larry? There we go. Thank you. So pathophysiology. So really pathophysiology, and we'll go through a couple definitions here later as well. But pathophysiology is basically just the study of what is altered causing diseases, okay? So pathophysiology is a physical explanation of why a normal process has become abnormal. And typically there's two things that can cause changes to organs, cells, and systems as a whole. And that would be a disease state or a response to injury. And we're going to have a nice lecture, not by me, but I thought it was so concise about inflammation. Inflammation is kind of the root cause or the start of all of the cellular or tissue destruction that can lead to organ failure, disease states, and just the compromise of the host as a whole. And when we compromise things in the body, it damages them. And if we're not able to recover from that damage, it can proliferate. And when it proliferates, basically it can go up to death, right? So you can have somebody who has an infection, but the infection becomes septic, and then the bacteria and the infection overwhelm multiple organs in the body, and you have multiple organ failure, and then you have death. Or you fix it with antibiotics, and it takes care of the problem. Does that make sense? So it's the study of what is abnormal causing the disease process to begin. So, you have to know a little bit about this stuff, just because we need to be able to go into somebody's home and do the following. We need to anticipate there being a problem. You know what? I stepped on the nail and my foot's red. Well, that's going to be a problem for the diabetic, right? Because we have poor vasculature to the extremities. The extremities are the furthest away from the heart as it is, and they're the most smallest micro vessels, blood vessels. And yet, we've got now a foot wound that's maybe not going to heal, and it's going to actually get worse. So we need to be able to anticipate the situations. We need to be able to correct the problem, right? We need to be able to intervene, whether it's, simple things like elevating the leg or putting the patient on some diuretics if it's like a heart failure or edematous state. And then, anticipating and knowing and correcting the problems, we're going to be providing them the appropriate care. But we've got to understand the disease processes so that we can provide the appropriate care. I think we all know what homeostasis is. Cannon defined it back in 32, it says here, but it's, Greek for the same or steady. And that's our body. We want to have it in a steady state. And when anything is out of sorts due to illness, injury, disease, etc., adjustments occur. And so basically, we fall out of homeostasis when there's a problem, and we need to be able to fix the problem, but we want the body in that normal state, and everything works together in harmony. Okay, so we got to go about cells. So this is more biology, right? We got specialized and non-specialized cells. So when we talk about specialized cells, we're talking about cells that are organized to do something. So they create tissue, they create muscle, they create, an organ. And non-specialized cells would be something like a stem cell, which is your immature, basic beginning cellular level. So you hear a lot about stem cell research and stuff like that. And they're working to develop ways to make these stem cells or these immature cells into things, organs, tissue, etc. And they're finding some success with that. When we talk about, specialized cells, it just says here they perform, specialized tasks. So this is the basic cutaway view of the cell. And the main components of the cell, obviously are the cell membrane, and that has some permeability, which means things can pass through it. via diffusion or active transport, and we'll talk about that here in a little bit. The cytoplasm is the internal fluid that will house many little ribosomes and macrophages and microtubules and all kinds of things that help support the life of the cell, lysosomes. And we'll talk about some of those in a minute. And then the nucleus, which is the heart or the main brain of the cell. Obviously, there's not a brain, but the nucleus is where all of the RNA gets housed. And then that can turn into DNA with the double-stranded helix. We'll talk a little bit about that too. So again, the nucleus has the genetic material. The nucleoli has the RNA in it. That's where that first genetic component will live. And the chromatic houses the genetic material. And then the fluid that has the organelles is the cytoplasm. So again, I talked through a few of them, but we got ribosomes, Golgi complexes, lysosomes, and mitochondria. And those are all the internal organelles in the cytoplasm. So if we go through, if you look on page 129, it talks about what each of those cells does. So, or the organelles does. So like you have the ribosomes, that's what interacts with the RNA from other parts of the cells and then starts connecting those amino chain acids to form proteins. The Golgi complex creates sugars for energy and carbohydrates. So it's a protein molecule, basically. The lysosomes, those are the digestive system of the cell. The mitochondria is the energy forming. Mitochondria produces ATP, which allows active transport. It takes energy to transport some molecules through cells or through cell membranes, walls. So that's on page 129, and you can go through those and look at them. Is it super important that you have a firm grasp on it? No. So fluid, a large part of the body is made up of water, and we should consume about 2.5 liters of water a day. So that's 2.5 milliliters or 2,500 milliliters of water. And the reality is that many of us are underhydrated. And there's two things that I speak of when I have people who are ill for proper healing or proper, fighting of a virus even. It would be good nutritional status, super important, and good hydration status. So they're a little bit different, right? So calories in for nutritional status, and then fluid in for water status. And I'll always speak that we have to have at least a minimum of 2 liters of water a day. And most people, especially the elderly, will scoff at that. And they'll be like, oh my God, that's so much water. I'll be up peeing all the time. Well, that's good. We need you peeing. We don't need you just dehydrating and then everything gets dehydrated. Your saliva, your mucus gets thicker. You can't express it out of the lungs better. Everything just gets really dehydrated because we're losing 60% of what we consume daily in urine. And, we sweat and we breathe and we're losing 28% of that 2,500 milliliters through the skin and lungs. And then we're pooping and poop is hydrated and we're losing 6% right there. And then they got the sweating as well. But, our skin and lungs and feces and sweat, that accounts for, just under half, right? So it's not that we're just peeing it out. It's that we're also losing it through other forms. And so nutrition status going forward for you as a community paramedic and hydration status are going to be super important. Okay. So here, I just want to also mention that I don't have Teams up. And so if there's a question, just pop in for me today. Okay. So go off the mic and just be like, hey, stop. I got a question. If you wouldn't mind, ladies, please.
Patrick, are you able to see the chat line?
I am not.
Oh, okay.
Is there chatting going on?
No,
Okay.
no, but there's on the bottom of your screen, do you see a chat button?
I don't.
Oh,
Oh, it's up top. It's at the top of my screen.
yeah,
Maybe
if
I
you
can
hit
move
that,
it
you
down.
can break it away a little bit.
Okay.
And then if they put in a question in the chat, you should be able to see it.
All right. Sounds good. It'll pop up maybe. Okay. So, water, we have to have hydration, water and solutes. And when we say solutes, we're talking like sodium, potassium, the cations and the anions. And cations and anions are they negatively charged or are they positively charged? So, a cation is positively charged and an anion is negatively charged. So if you take, for instance, normal saline, right? It's NaCl. So it's Na plus sodium and Cl negative chloride, and they attract each other, right? Opposites attract. And so when I speak of cations and anions, that's what I'm speaking about. So when we talk about the movement of those ions or those solutes through cells, blood vessels, and connective tissues, we're going to talk about how they go through it. But water is what helps facilitate that, okay? And we'll talk about osmosis and stuff too. But we have two forms of moving those solutes into and out of cells, blood vessels, and connective tissues, right? We have passive and we have active transport. Now I can't move my thing. There we go. So active transport uses pumps. And remember I said stuff that's active requires ATP, and that's energy that's created by the mitochondria, and it allows the energy to suck in or spit out one of those solutes, okay? And a solute is simply soluble in water. So you go from active transport, the pumps, you go from an area of low concentration to an area of high concentrations, and water moves between these fluid components via osmosis. So, when we're diffusing water, it can flow freely from areas of low solubility to areas of high solubility. And this is the famous sucrose molecule experiment. Many of you probably in anatomy and physiology did this when you were learning about osmosis, but it's really depicting you have a bag that has solute in it on the left there, A. And, in this case, it's sucrose, and that's sugar, right? So we have sucrose there, right? But the amount of solutes in the bag that's permeable as opposed to the amount of sucrose that's in the beaker is different, right? You don't see any solutes in the fluid outside of the bag there. So what happens is water filters through the cell membrane in this case, it's a bag that's permeable, and it makes the bag bigger because it sucks in volume of water. And so that's why B looks bigger than A. It's because osmosis has pulled in fluid and it's going from an area of low concentration to an area of high concentration because it wants to equilibrate. So talking about water, you know, plasma makes up 55% of the blood, right? So the components of blood, you know, plasma, 55%, platelets and white blood cells, 1%, and then 44% are red blood cells, okay? And so the biggest component of blood is 91% water. And so that's why hydration is important. And that's why when we give somebody an IV and give them a fluid bolus, you know, we're able to increase volume within the vessel, right? It does thin out the blood. However, it does improve volume in the vessel. And if for whatever reason the patient was underhydrated, it will provide them the ability to absorb the water into the cells and into the tissues that are maybe depleted. Okay, so this is a key point here, under normal conditions, okay? And so we're talking about what happens. So the amount of fluid filtering outward through the arterial ends of the capillaries equals the amount of fluid returned to the circulatory or the circulation system by reabsorption at the venous end of the capillaries. So really what we're talking about here is with regard to blood vessels, right? Arteries and veins. We have, you know, arteries go down to arterioles, you know, very small, then go down to the smallest component of capillaries. And that's where the exchange of oxygen-rich blood goes into the tissue. So let's say we're talking about a blood vessel that feeds the kidney tissue, okay? So the oxygen-rich red blood cell feeds the demand of the kidney tissue, and then subsequently in this finite mesh of crossing over arterioles and venules at the capillary level, which is where they kind of cross the bridge, you have the reabsorption of the oxygen deficient blood. And so what also happens at that area is fluid or water gets expressed out, okay? And then it can get reabsorbed in. So let's say you have a ounce of water that gets expressed out at the arterial side of the tissue. The venous side of the tissue, which is right there, reabsorbs the ounce of water, but the ounce of water that it reabsorbs, you know, has the trash in it. And then that goes back to the heart, you know, gets filtered out through the liver and the kidneys, and it creates urine, and it keeps our creatinine low. So creatinine, I like to think of as, in simple paramedic terms that I always appreciate, crap in the blood. Creatinine is crap. The higher the creatinine, the more crap or dirty blood you have. Okay, so the liver's not working well, the spleen's not working well, the liver's not working well, something's not working well causing that. And typically it's the kidneys, okay? That makes sense. Just give me a piece of feedback on that, please. Somebody. Anybody?
It does.
Okay. Okay, so I think we talked about capillary membrane permeability and how it plays an important role of moving fluids. Remember, capillaries are the end stage of the arteries and the beginning stage of the venous system, okay? It moves our fluids around. That's where we have problems with edema starting. And if our permeability of the capillaries increases, the membranes begin to leak. And when you leak, you're letting out more ounces of water into the tissue than you're reabsorbing on the venous side. So then we can get the edema, right? And that's just the accumulation of the fluid. Legs are always going to be the most edematous because they're dependent. They have to not only fight gravity, but as they swell, they start to compress the venous system. So then the venous system starts to cause reflux, and you start getting tremendous, what we would call head pressure. So where, let's say, somebody is sitting and they have 10 pounds of head pressure, and the heart's able to provide 12 pounds of venous pressure, you will get your blood recirculating through your legs. Now, if your heart is weak and it's only doing 10 pounds of pressure on the venous side, and you have capillary leakage that's caused edema in the legs, which has caused pressure on the veins as well. Now you have a compressed venous system, which creates resistance. And then that resistance now makes it that it's going to take 15 pounds of pressure to flow the blood through the venous system, and the heart's not able to do it. And then so it's just that big compounding effect. And those are extreme examples, but I think that they paint the picture of what I'm trying to explain well. So hopefully that made sense. So this is going to be a picture of edema in the right arm, or left arm, excuse me, left arm. This is a elderly woman who had a mastectomy, a unilateral mastectomy there. And although this talks about edema, it's not going to be the same type of edema that we would see necessarily in the legs. This is going to be lymphedema. And this is due to a disruption in the lymphatic system, which is essentially the third circulatory system of the body. And so what happens is we get lymphatic vessel obstruction secondary to, in this case, the mastectomy and the removal of multiple lymph nodes within the chest and probably the axilla. And so it's really just, unfortunately, destroyed the lymphatic system, which doesn't typically heal very quickly. It's a very, very fine system. And when it starts to get disrupted, it can cause problems. But this edema is lymphedema. And you can get lymphedema in the arms, you can get it in the legs. Okay, so people who have had inguinal trauma or inguinal lymph node biopsies, etc., you can have the lymph system back up. And then I'm just going to throw it out there. The third reason we get a lot of swelling in extremities, especially the legs, is because of peripheral vascular disease, where the vessels in the veins get damaged, or they get compressed due to obesity, etc. And what happens is the little valves in the main veins of the leg don't allow the pressure to be relieved. And so it's a head pressure issue. Those people you will say, at the end of the day, are your legs more swollen than when you first wake up in the morning? And they'll typically tell you, oh yeah, my legs are perfectly normal in the morning, but at the end of the day, they're horribly swollen, but they get fixed every night. That's not fluid or peripheral cardiac-like edema. That's not lymphedema. Lymphedema doesn't go away either. That's going to be peripheral vascular disease that causes that. And that's just a little FYI bonus that I'm throwing in there right now for you. So, we talk about fluid and electrolyte balance, and this diagram basically, I'll talk about it. So if you look to let's look at the brain first. So if you look at the image to the right, if we have an increase in osmotic concentration, that means that we have an increase in solutes, right? And so we need to maybe retain more water, right? Or excrete more solute. So basically the receptors in the hypothalamus are going to sense that, okay? And then what's going to happen is the pituitary gland is a very, very important gland. It has many functions of secreting hormones, okay? So thyroid, TSH. In this case, we're talking about ADH, which is the anti-diuretic hormone. And when you say anti-diuretic, you have to think, well, what's it doing? Well, it's holding on to water, right? It's anti-diuresing. And so just think of it that way. And so what that's going to do then is that's going to increase the permeability of the distal convoluting tubules in the kidneys, right? And that's going to allow there to be more free water reabsorption, and it increases blood volume through retaining water, and it will reduce the osmotic concentration, right? So if we have a really salty meal, what's the first thing we ask for? We ask for water. And so it's just trying to balance out the acute increase in, sodium in the body, or that solute, okay? And then once it returns to a good homeostasis state, which is just a normal balanced state, it sends back a signal that tells the brain that it's had enough, and the pituitary gland shuts down, and it just stops the stimulation. So on the other side, fluid balance is created if there is a drop in blood volume or blood pressure, right? And so we have alpha receptors in the heart, and they will sense the need for increased blood volume. So either, let's say, in our case, EMS trauma, right? Or in maybe a rectal bleed situation, a bad nosebleed, or just some insidious bleeding that's occurring in the upper GI, and the patient's not, sensing the tarry stools or anything like that. So what happens then is the heart alpha receptors will send a note over to the hypothalamus, which then triggers its friend, the pituitary gland, to secrete ADH, right? Anti-diuretic hormone. And then the whole system starts over again, right? The kidneys start collecting fluid in the distal tubule, and then it increases the blood volume, which returns it to a normal homeostasis type state, and then it shuts things down. And so the two things that are really important here are the ADH, right? The anti-diuretic hormones spit out from the pituitary gland, And then something called the RAS system, the renin-angiotensin-aldosterone system, which is the system of the kidneys. The liver's involved just in some converting of things, but really it's the kidneys, and it's the ability of the kidneys then to sense the need for water being held on to, or solutes being held on to. So if we're low sodium, we would hold on to some solutes in the kidneys, okay? So here are those three sensors that are in the body. Osmoreceptors or osmosis, that's the receptors that talk about what concentration the solutes are. Volume sensitive receptors, so those are alpha receptors in the heart. And then baroreceptors, and those are also throughout the body, which talk about pressure. So those are going to, so the arteries have a lot of baroreceptors associated with them. So I wrote down some notes here: osmoreceptor, hypothalamus too, volume sensors like the atria, the top of the heart, and baroreceptors are in the kidneys, aorta, carotids, etc. Just as some examples there. Okay. Everybody doing okay still? Let's see how much time we got.
Yep.
Okay, good. Let me take a swig of coffee here for a minute. So electrolytes are anything that's positively or negatively charged, right? So when we talk about electrolytes, everybody says, oh, you got to drink your electrolytes. Well, really what it is, it's like these elements that are positively or negatively charged. So in medicine, there's a lot of synonyms, okay? And so, you know, electrolytes is just this like broad term that's used to talk about, you know, positively or negatively charged elements. And there's some main components in the body, and they're listed here. You know, sodium, chloride, potassium, calcium, phosphate, and magnesium. And these are really the big players in what helps keep the body in its normal state, and it helps with transporting and triggering action, right? So the repolarization of the heart, the repolarization of muscle fibers, cardiac muscle, etc., right? It's all done by these elements that are mainly intercellular that transport out, or extracellular that transport in. So they cross over, right? So water and electrolytes here. This is the RAS system, okay? So sorry, this one was a little out of place, but what we have here is, let's say, reduced blood volume, hypotension due to, let's say, you know, vasoconstriction, or low sodium, right? So the juxtaglomerular apparatus in the kidney senses this, okay? And then it will secrete renin. And then renin gets converted to angiotensin, then gets converted to angiotensin 1, right? So it pulls it over. It gets converted to angiotensin 2 in the liver, okay? And what happens is angiotensin 2 then will create vasoconstriction, which can help improve hypotension and reduced blood volume, right? But it also then, angiotensin 2 can also then convert to aldosterone, okay? And that is secreted by the adrenals. And the adrenals really create steroid for the human body. And that's going to be important for you as you start to learn about how prednisone, which is a steroid, over long term can affect the adrenals, right? So anyway, the adrenals then get triggered and you will retain water and salt, okay? And so that's kind of how the RAS system works in a real basic form. Angiotensin 1 gets converted to angiotensin 2. Angiotensin 2 on its own creates vasoconstriction, which helps with the plumbing. And then angiotensin 2 then can trigger aldosterone, which gets secreted and triggers the adrenals. And then the adrenals, the steroid will help retain salt and water. So if you go back here, when you're talking about ADH, that is one way of helping fluid balance. And then now the RAS system here explained is the other way that you can help with osmolarity differences, fluid increases, etc. And it's using, well, it's not using these electrolytes, but see, this slide should have been a little bit forward, and I apologize. I didn't catch that when I was reviewing everything. Okay, so now we'll talk about alterations in electrolyte balance, right? So we're talking about the electrolytes being abnormal. So shifting gears from what can create increased water retention or increased blood pressure or blood volume, we're now going to talk about electrolytes and how they move and what they do. So sodium, high sodium hypernatremia, low sodium hyponatremia. You know, we can lose sodium through sweating. We can lose sodium through GI issues, let's say like excessive watery diarrhea. And so we just can lose a lot of sodium through those means. We can have hyponatremia, okay, that is caused by excessive water intake, right? So if we're flooding the body and we have an issue with being able to, let's say, excrete urine, or we're just excessively hydrating, we can really thin out our sodium that way. And then opposite of that, hypernatremia can be created through lack of water, right? So we're not able to excrete out the necessary sodium that's over what we should have. So basically, there's other ways that sodium can be, you know, high or low, but in this case, we're just kind of keeping it at an example of, let's say, sweating or GI issues, right? So chloride runs with sodium, right? Positive and negative anion. So you see there that sodium down here is on its own, and chloride up here is on its own, and then it's got this shell of hydration around it. And basically, it's important to know that, you know, in water, sodium can separate into its original ionic state, right? So you could have sodium and chloride separate, right? It's not sodium chloride together. It just can separate out, and it helps regulate the acid base balanced that way. So potassium is a major intracellular cation. It's a positive, it's K plus. And it's a critical element that is really important. It can affect cardiac tissue extensively, and it's got a real finite range, about 3.5 to 5.5. And you can spill potassium in your kidneys pretty easily when you're on diuretics. Typically, we need to be giving potassium supplements to people who are on Lasix or torsemide or umetanide or anything like that, and you can just excrete it out. It just pulls right out with water pretty easily. And basically, it works in controlling muscles, the three muscle types, right? Smooth muscles, cardiac muscles, and skeletal muscles, right? So it regulates those. So the potassium moving in and out of the cells of those muscles cause it to contract and then relax. Also helps, of course, with acid base, and helps with intracellular osmolarity, because if a positive K potassium moves out, another positive has to move in, and a lot of times that's sodium. So the basic terminology or definitions for hypo and hyperkalemia: again, hypo, low calcium; hyperkalemia, high potassium. So did I say calcium? I didn't mean that. I said hypokalemia is low potassium, hyperkalemia is high potassium. And so a lot of times, if we're talking to, let's say, our supervising physician, we would say, hey, you know what, this guy's really, hyperkalemic, and we need to do something about that. And so we'll give them some calcium to bind that up. Calcium's in the bones. It is the sole reason that we have strength and stability in our bones. As people age, they become osteoporotic. And so people on a lot of steroids, or women due to menopause, stop really building bone and depositing calcium in their bone. And what would be typically dense in all of us here today becomes very honeycombed and weak as we age. Again, unfortunately, women are bearing the brunt of this more so than men, but we also worry about folks that are on long-term steroids that can cause osteoporosis as well. And basic general terms here: the hypo calcemia is low and hypercalcemia is high. And so if we have low calcium, a lot of times it's decreased intake or the ability to absorb it. So calcium requires vitamin D to absorb it into the bone. And a lot of us here in Michigan don't get a whole lot of vitamin D. If I was to probably test 100 patients, I bet 90% of them would come back with below normal vitamin D. And so as we age, vitamin D supplementation is very important, because that will help transport the calcium into the bones. So if we have somebody who says, oh, I take a calcium tablet every day, I'm taking 1,200 milligrams of calcium every day, but they're not taking any vitamin D, it's not going to absorb. Another reason that calcium won't absorb is a result of poor nutritional status. And I can't stress that enough again, right? Here we are talking about water. I think we have a good understanding about hydration needs, but here we are now talking about, electrolytes, and nutritional status is a real big form of where we get all of these electrolytes. They aren't magically, just being absorbed into our body. Now, sunlight gives us vitamin D or produces vitamin D, but what I'm saying is we don't get enough sunlight here, so we need to add a bit of a supplement, or we need to eat a really good balanced diet. And, they have vitamin D fortified milk. So other reasons for hypocalcemia, we can have an endocrine disorder. So sometimes thyroids can cause that. And then we could just have increased loss of calcium. A lot of times increased loss of calcium is secondary to a parathyroid issue potentially, or a malignant state. And so we could have low calcium content in our bones, but we could have high calcium extra cellular as a result of malignancy. So although it doesn't cause hypocalcemia, it does affect our bones quite substantially. Malignancy does. That's one key sign. Everybody's looking for signs for cancer and stuff. That's one key sign. If you chronically see somebody with a little bit of an elevated calcium, we should at least, look at what's going on with the whole body and see if there's something going on. It might be an early sign that we're going to be fighting a cancer soon. So we talk about hypercalcemia. That's increased serum calcium, right? We have increased intake. So we're just drinking milk like it's going out of style. Again, endocrine disorders can cause that. Neoplasms, we just talked about it. Cancers can cause it to be high, leaches that out of the bones. And there's other various reasons we can have high calcium. Phosphate is, we really get into phosphate when we get renal disease going on, kidney disease, end-stage kidney disease, dialysis type patients. It's kind of the lost, forgotten about molecule, phosphate, and it's essential, and it's utilized in many body functions. Let me see if I wrote down a couple of notes on that. Yeah, so phosphate, ETOH abuse can reduce our phosphate. Chronic kidney disease, like I said, it can cause bone and muscle dysfunction, and that's pretty much all I had for that. It's like I said, the long forgotten about molecule. Phosphate is a molecule. Magnesium, okay, it is important intracellular. Magnesium is stored in various ways, 49% cells, 50% bones, right? So about 50-50 bones versus cells, and then 1% in the extra cellular fluid, hypermagnesium, hypomagnesemia. I had a hard time with that. We know about acid base. We know that 3.5 to 4.5 is going to be the basic neutral plane for us. Basic is going to become higher to 14, and acidic is going to become lower towards 1. But 3.5 to 4.5 is where we want to be. We have a natural buffer system, whether it's through the lungs or through bicarbonate. And that helps us keep this balance in play. The buffers combined with hydrogen ions to manage the fluctuations in acid-base levels. We know about acidosis and alkalosis, too low, too high. We have metabolic and respiratory phases of that. The imbalance occurs when our buffering capacity exceeds our imbalance. So here, let's talk about metabolic acidosis. And we're going to be kind of coming close to the end here. So just bear with me a little bit further. Metabolic acidosis, we have metabolically, we're kind of retaining those hydrogen ions, right? And what can cause metabolic acidosis? DKA, right? Sepsis, infection, and the example here shows that we have the bicarbonate and the carbonic acid. So, we have the CO2 that is heavy, and we're now becoming more acidic, right? We're going from 7.4 down to 7.0. Well, we need to increase our bicarbonate, and so sodium bicarbonate then gets converted in the body, and it brings our pH range back to 4. Respiratory acidosis, on the other hand, is we have additional carbonic acid that is being retained, right? And so we have that CO2 that's going up in the blood, and it's causing us to be more acidic. And so we need to create additional bicarbonate and get that pH range back to 7.4. So in respiratory acidosis, we could have lung disease, or we could have hypoventilation or cardiac arrest, right, etc. So metabolic acidosis is caused by a disease process, sepsis, or DKA. Respiratory acidosis is caused by the retention of CO2. Respiratory alkalosis then is where our carbonic acid, our CO2, is lost by hyperventilating, or let's say we have a PE that's causing poor gas exchange. So pulmonary embolism, blocking one of the main pulmonary arteries into the lung, either side or both sides, and it's causing us to have a hypooxygenated state where CO is increasing, or a hyperventilation state, but nonetheless, the CO2 is increasing, right? And caused by a serious disease, right? So in that case, we're now going over to the basic side, more towards, 10, 12, 14, and we need to reduce the amount of bicarbonate in the body, and that will bring us back to our normal homeostatic 7.35 to 7.45 pH state. And those are the respiratory alkalosis, respiratory acidosis, metabolic acidosis, and you can also get metabolic alkalosis, and that could be caused by diarrhea. So cell signaling and feedback is basically the cells communicating with each other. They can trigger chemical reactions and provide negative feedback. So for example, a form of negative feedback would be, again, the pituitary gland spitting out TSH. So TSH is thyroid stimulating hormone, okay? And that the brain is sensing that the thyroxine in the blood from the thyroid is low. And so if there's low thyroxine, the brain will spit out TSH, thyroid stimulating hormone from the pituitary gland. That hormone then will trigger the thyroid to make more thyroxine or T4, and then it will spit out more T4, right? And so that is like a negative feedback loop, right? So positive, so low thyroxine means that more TSH is going to be spit out by the brain, and so it's relative. So let's say you have 10 thyroxine and you should have 100, right? That's going to trigger a higher TSH response down to the thyroid than us having 99 thyroxine. It would be a much lower positive thyroid stimulating hormone trigger to the thyroid at that point. And then when it fixes it, it'll shut the TSH off, right? Subsequently, if the thyroxine is too high, the TSH that's being trickled down to the thyroid will lower. So if you have high amounts of the active metabolite thyroxine in the blood, that would cause the brain to reduce its dispensing through the pituitary of TSH. So that's kind of how a negative feedback loop works. Ligands and receptors, basically, a ligand is an ion or a molecule, and a receptor is simply a receptor port in the cytoplasm, okay, of the cell. Ligands includes hormones, neurotransmitters, and electrolytes, like we talked about. A molecule that binds to any receptor that leads to any reaction. So that would be ligands and receptors. And this is cell signaling and feedback we're talking about. So, you know, we can have alterations in that if we have electrolyte imbalances. We have, you know, when normal cell signaling is disrupted, we have a disease that starts. And so if we have the inability for cells to communicate with each other and then transport those ions across the membranes and keep the cells at a normal homeostasis point, then the tissue will start to become diseased. And whether that is disease in renal failure, diseased in, you know, you name it, cardiac failure or cardiac tissue health, vasculature health, liver health, thyroid health, etc. When those cells start to become interrupted and they aren't able to provide the information back and forth and the feedback, that's when diseases will start. Right there, many human diseases are attributed to malfunctions in the cell signaling process. This is some basic tissue review. You know, tissues are a group of cells working for a common function. So tissue can be skin, right? Anything, even though the skin's an organ, it's made of tissue, right? And even though organs are organs, it's a group of tissue that creates the organ, the spleen, the liver, the heart, the kidneys, the adrenals, the parathyroids, the thyroids, the brain. So you have these organs, right? So all these tissues are coming together to form a common purpose, right? So tissue is the simplest level, and then that becomes an organ, and then you get the organ system. So, you know, if we talk about the lymphatic system, you know, that includes the tonsils, the spleen, the lymph nodes, and then the lymph ducts, or the vasculature of the lymph system. So that would be an organ system of all of these tissues creating organs, and then all of the organs working together to do a job. And the lymph system would be to help keep the body from having illness, bacteria, infections, insults, etc. So yeah, we have the types of tissues, epithelial, is kind of the outer layer, and basically, muscle tissue. Adipose is fat. Connective tissues can be bones and ligaments, cartilage, and so that's the basics of the tissues. But epithelial, kind of you think of the epithelial layer of the skin. Okay. So this is what happens to cells. They adapt to protect themselves from injury. Atrophy is simply small, the cells shrink. So if we have an organ that's, becoming atrophied, a lot of times the human stomach will become atrophied with age. That's why old people are always like, plate of food's too big, and you're like eating it, like it's nobody's business. Atrophy is the shrinking of the cell sizes, and as we age, a lot of things in our body begin to shrink. Hypertrophy is increased cell size, so that would be like the heart becomes hypertrophied due to blood pressure. So you have somebody who has had uncontrolled blood pressure for 20, 30 years, never went to the doctor, they got this big old heart. Or alcoholism, has caused hypertrophy of the heart, so it doesn't work so good, so they become increased in size, right? Because really at the finite level, it's the cells that are becoming bigger, which is making the tissue bigger, which is making the organ bigger, which affects the system as a whole. So hyperplasia, so we think about this in like skin cancers and things like that, where the number of cells just proliferate. So you might see a lot of skin cancer on somebody's head, and it's just really growing. Cancer tumors, etc. The cells are just proliferating, okay? Dysplasia is going to be precancer. That's really what that is. Dysplasia is a change in the size and shape of a cell. So let's say you have a colonoscopy and they take some biopsies from your colon, and some of them are dysplastic, or this is dysplasia noted, or let's say an abnormal pap smear or something like that. That would mean that there's a problem with those cells. And when there's a problem with the cells, what does that lead to? Talked about it earlier. It leads to disease, right? And in this case, we would be concerned for cancer. Metaplasia is going to be a change in the type of cell. And so that's kind of interesting. You might have cells that take over. And again, that would be in a disease state where the abnormal cells really start to take over. And that would be best described, let's say, in like an autoimmune type situation where your body is really creating its own havoc from within and causing changes to the system, to your body, psoriasis, for example. Okay, and then there's one term that's not on here, apoptosis, and that would be cell death. And so, in wounds, necrotic tissue, anything that's diseased to the point that, it cuts off the blood flow and becomes necrotic. Apoptosis is the term that is used for cellular death. These are things that can affect cells, right? We talked about all of that. We'll talk about inflammation a little bit. This talks about cell death. We talked about that. Irreversible is cell death. Healing, we'll talk about this in the wound portion, which is my last slide of the next lecture. But the 4 steps are repair, removal of the trash, restoration of the tissue, and regeneration of cells. You can get about 80% better at 3 months on most things with normal healing. Healing by primary or secondary intention. So do we suture the laceration closed? That's primary, okay? Secondary would be we are leaving the abscess that we drained open, and it's the size of a baseball, the cavity, and it needs to heal from the inside out slowly. So that's healing. So primary, we're assisting it. Secondary, we're just letting it heal on its own, leaving it opened, and just keeping it free from bacteria through simple washing, etc., packing, whatever we might do. We're going to talk about inflammation here in a little bit. It's our protective response to our tissues. Our immune system provides the best defense and removes bacteria and viruses. So we have two types of immune systems. We have the innate, and then we have the like the man-made, like we do vaccinations and stuff like that. We have immunity caused by anatomic barriers, which would be the skin, the inflammatory response, and then the immune response. Again, that's antigens and antibody that creates memory cells, etc. The immune system, again, has the lymphatic system associated with it. The lymph is the fluid. The lymphoid tissue is the the tonsils, the spleen, that sort of thing. And then white blood cells are our bacteria fighters in our bloodstream. We're going to talk about inflammation again, a little bit more detailed, but it's basically, rubor, color, dolor, right? Red, hot, tubor, swollen, and painful. So the cardinal signs of inflammation are pain, swelling, redness, and heat. What are the cardinal signs of infection? Pain, swelling, redness, heat, right? So it's like it takes a little bit of understanding the front story before we say, oh, that leg is inflamed, or boy, that leg is infected. So infection and inflammation run hand in hand in their signs that we can see. And it's important to understand what's going on. It goes back to the front slides. We have to have a clear picture. It's going to help us make a determination on what needs to happen, whether it's anti-inflammation, elevation, compression socks, or, IV drip vancomycin, because he's got or she's got a horrible leg cellulitis that's been unattended for 10 days, and now he's got a fever. So the cardinal sign for bacterial is always going to be fever. But a lot of times you'll look at something and the patient won't have a fever. Then there's other things like, did they have chills? That's a good sign too. Inflammatory response is triggered by injury or infection, can be acute, systemic, or chronic. So acute would be, I stubbed my toe. Systemic would be a disease process. And then chronic would be also caused by a pretty significant disease process. We'll talk about those. Two types of immune responses, native, right? So they're just inherent to us. They're our first lines of defense against pathogens. It's our white blood cells. It's things that we've acquired through our maternal blood supply as we were being created as an infant. And then acquired would be methods that we've gotten through immunizations or illnesses, right? So we can have active or passive. So, you know, we can have illnesses where we caught influenza, you know, strain, you know, XYZ. Now we have a acquired immunity to influenza XYZ. However, we didn't have acquired immunity for H1N1 flu, and we went and got vaccinated for H1N1 flu, which created some passive immunity for us. And we have cells that run around remembering how to take care of those illnesses. Antigens are what is the insult into our body, and we create antibodies to fight those off. So the B lymphocytes are what produce antibodies, and then the T lymphocytes create cytokines or the killer cells. So when we talk about our immune response, antibodies are produced by the beta cell lymphocytes, and then we have the killer cells that go out and gobble up all of the garbage or the disease, the virus, and those are the cytokines or the cytotoxic killer cells. There's a depiction of what we talked about, you know. Goes without saying, right, as we age, we're more prone to infections and we recover more slowly. As infants, we're slower to become ill, although it seems like babies are sick a lot, but we're slower to become ill, and we have a slower inflammatory response. We have much more subtle signs of things when we're an infant. And that's all I got for the book's pathophysiology. Can I have some comments, questions, or concerns?
I think
Anybody?
things went very well.
Okay, it's a lot of information. I'd like you to just go back and do it if you want. How about everybody turn on their camera for a second? We'll just have a little quick conversation before we take a break. And Angela, I know you're driving. You still with us?
Yeah, I'm still here.
Okay, did that all make sense, not being able to look at the slides?
Yes, it does. I had A and B back in college, so now it's kind of puts it in a very simple, much easier term.
Yeah, right. Yeah.
Here's the meat
Yeah,
and potatoes. This is what you need to know.
right. And you know, all of this stuff isn't to like, you know, make us pre-med, right? You know, none of us are here for pre-med, but the reality is that it just gives us a little bit of a snapshot of how things work and why. And, you know, I don't sit there and think about pathophysiology necessarily every day I'm treating somebody. We aren't going to be out as community paramedics, you know, trying to think through the pathophysiology of stuff all of the time, but it might make sense when we see something, we go, okay, this is why we're having a problem, whether it's a vascular issue or a fluid overload issue or a electrolyte imbalance. So this is all going to build on you guys now being taught about abnormal labs, right? And we can kind of understand why, you know, the abnormal labs are important and what can happen. And so we're going to take a break here and we're going to transition into the slides that I created that are going to go through the top 10 plus 2, I say, top 10 plus 2 reasons for readmission. We're going to start off with a basic explanation via YouTube that I thought was so concise and well put together, I couldn't leave it out. I had to use it, right? I was trying to figure out how I was going to explain inflammation, because inflammation is a big deal in the overall health state of patients. And it's really the root of a lot of evil. It could be good too, though, right? It's when inflammation gets out of control that overwhelms the body and it knocks us out of that homeostasis type state. Okay, so let's do this. It's 9:22. How about if we come back at 9:35? Okay, let's all take a little bit of time, use the bathroom, get a cup of coffee, relax, whatever. We'll come back at 9:35. Okay.
Okay.
Sounds
So
good.
good.
Perfect. Thank you.
Dang it.
Patrick, are you gonna put notes on this other section that you're gonna be talking about? On
So I'm gonna post it to the Moodle. I just didn't do it.
Okay.
I'm a little Moodle incompetent at the moment. I'm gonna get better.
Understandable.
And it's gonna be up for you guys. I also have to put my sources on it because there's some sources that were used and I didn't have those ready to go. And I didn't want to post it up for you guys to have access to it or other people to have access to it without some sources cited because, you know, I want it to be all legit and legal.
I
Yep.
will try this afternoon when Clark gets back in the office, or if Jay knows how. Yeah, once this is over, probably in the next couple of hours afterwards, I'm gonna take this recording and post it back.
Yeah, that's
So
cool.
they'll be able to see it too.
What's up, Dan?
Dan's being quiet.
Yeah, that's okay.
Mhm.
Stealth.
He's hiding in the closet.
Amanda's not back.
I don't think anyone can hear me. Nope, you're right.
What's up? Jordan? That's not Steve either. Is Amanda back? I have the screen.
Yes, you should have everything. I didn't take anything away.
Cool.
There you go.
Hey. You with us, Angela?
I am. I made it home.
Good for you. Good deal. Amanda, you with us? Well, we're going to get started. I wanted to point out in the book on page 132, there's a nice depiction of cellular transport through cell membranes, right? So simple diffusion, you know, just goes right through the cell membrane. Protein pores is kind of like a gateway for the diffusion of molecules to go through. And then you have the facilitated, where it takes no energy and it's just an open. So that's the key and lock type transport that's spoken about, where only in this case, the sugar molecule will fit into that specific form of the protein, and then it locks down and then spits it out the other side. And then you have the active transport, which shows that ATP being used, where there's a port for it, right? But it attaches into it, and then ATP has to bind to it to like give it the energy to open on the other side. And so those are that's a really cool schematic that I wanted to point out. Also, on page 144, it talks about healing. You can go through that and look at it, but it's going to talk about healing and the inflammation process that way. But the one that I really liked and wanted to bring to everybody's attention was page 146 and 147. A lot of people don't realize that the lymphatic system is like our third circulatory system. I should say a part of our circulatory system, okay? Often we hear about arteries and veins, and really the lymph system never really gets talked about. I mean, we're yanking out adenoids and tonsils, and is it really necessary and all of that? Well, it's all created for a specific reason, right? It was all created to do something. Can we live without it? Yeah, you can live without your gallbladder, you can live without your appendix, you can live without your tonsils, right? But it was all created to do something, right? But anyway, I thought that picture B specifically showed a nice interaction of how the lymphatic system really integrates at the capillaries. Remember, the capillaries is that transition, if you will, from the arterial side to the venous side where everything gets exchanged. And that's at the tissue level, right? So it's all tissue gets innervated with these capillaries because we have to feed it oxygen and remove waste, right? And so I thought that B really depicted that nicely, where it shows the vein, the artery, and the lymphatic system all integrated. And in fact, on page 147, that picture that you see there really breaks it down and gives you almost a microscopic view, in essence, right, of how the lymphatic system sits right there at that capillars. And it's really a point where all the action's at, right? That's where everything's happening. And that's where stuff is going to be out of the bloodstream, transitioning into tissue. And that's really where the lymphatic system works to help with immunity, disease control, all of that sort of thing. So I thought that that was really a cool picture. And I wanted to point those out for future reference, okay? Great. So this is my presentation that I created, and I will post this up on Moodle. I just need to put some sources on it, and we'll get it up there, okay? But you know who I am, and I have no necessary disclosures. So this is that video on inflammation that I want to start off with, okay? And so I'm going to play this and just let it go, okay? And if you guys want to darken down your cameras, that's absolutely fine. If we need to talk, we'll just bring them back up when we need to talk. But this is going to be the start of the presentation on the top 12 disease readmission problem rate stuff. And you can see the video.
Yes.
Great.
Yes.
Thank
So
you.
this video is an overview of inflammation. My suggestion is that you firstly watch this one to get a general idea of what it's all about, and then later watch 2 other videos I have on acute inflammation and chronic inflammation, just to learn more details about inflammation. So an inflammation is the response of vascularized tissue to an offending agent. An offending agent can range from foreign bodies or infections to damaged tissues and many other things that later in the video we go through that. Well, I want you to pay attention to the fact that this only happens in vascularized tissue because we need blood to bring all the cells and mediators involved in inflammation. The goal of inflammation is to remove and eliminate the offending agent. So inflammation features have been recognized and known to people for thousands of years. They have even been described in Egyptian papyrus dating back to around 3,000 years before Christ. In inflammation, we have 2 5s. Firstly, the 5 cardinal signs, and then the 5 R's, which are the steps of inflammation because they all start with an R. So let's go through them. So the first five are the cardinal signs, which describe what an inflammation looks like. The first four of them are pretty easy, and I'm sure we have all seen them. They have been described by Romans for like as early as 2000 years ago. They are redness, swelling, heat, and pain, or in Latin, rubor, tumor, calor, and dolor. The fifth one was added in the 19th century, and it's loss of function, or functio laesa in Latin. What causes an inflammatory response? An inflammation can be caused by a variety of different agents, mostly falling under the following four categories. Firstly, infections, of course. The second one would be tissue necrosis, meaning necrotic cells. So it's important to know that necrosis causes inflammation because it releases the dead cellular content into the extracellular area. So to learn more about this, you can check my video on necrosis. The third one would be foreign bodies, for example, urate crystals in gout disease, or cholesterol crystals in atherosclerosis, or for example, lipids in obesity-associated metabolic syndrome. The fourth one would be immune reactions or sensitivity reactions. So that can be triggered by self-antigens, for example, in case of autoimmune diseases, or for example, environmental substances in allergies. Next, let's move on to the steps of an inflammatory response and see what actually happens during an inflammation. The steps of inflammatory response are also referred to as 5 R's, as I mentioned earlier. First one would be recognition of the injurious agent. The second one would be recruitment of leukocytes. The third one would be removal of the agent. Number 4 is regulation or control of the response. And number 5 is resolution or repair. But let's learn more about them a little bit more. Let's get into details of these steps. So firstly, during the first step, the offender has to be recognized. So this responsibility falls on macrophages, dendritic cells, and mast cells. If you want to learn more about these cells of the immune system, you can watch my video on that. Then the second step follows. Once these cells recognize the presence of an offender, for example, a necrotic tissue, microbes, or a foreign agent, they just secrete mediators of inflammation. These mediators can be amines like histamine or cytokines like interleukin-1. If you want to learn more about mediators of inflammation, you can watch my video on that. After having been released locally, mediators of inflammation promote a number of things. So firstly, dilation of small vessels. Secondly, increased permeability of the microvasculature, allowing plasma proteins and leukocytes to leave the circulation. And the third one would be recruitment of leukocytes and later their immigration from the circulation to the site of injury. So here we have a normal arteriole, and then we have an arteriole in case of inflammation. So please note how it's got dilated and note the distance between each endothelial cell. So the permeability has been increased.
Sorry about the glitchiness, but this is at the arterial or at the capillary end of things. Okay, this is at the smallest or next to smallest portion of the artery, okay? Just as a reference.
Increased permeability and interendothelial space results in fluid and protein leakage from the vasculature. So after having exited the vessel, this fluid, which is high in protein content and cellular debris, would be called an exudate. Exudate is what causes edema or swelling and inflammation, what we learned about in the cardinal signs. So here, please note the difference between exudate and transudate. So exudate is high in protein content and exits the vessels in case of inflammation. Transudate, on the other hand, is a fluid with low protein content and a little or no cellular debris at all. It exits the vessel as a result of an imbalance of hydrostatic or osmotic pressure. So the exit of transudate from the blood happens in the case of liver or kidney disease, in which we have, for example, too little protein production in the liver or too much protein secretion via the kidney, resulting in too little protein content in the blood, and therefore causing osmotic imbalance. A transudate is practically a filtrate of blood exiting the vessel to bring the vessel and its surrounding to osmotic balance. But then it's completely irrelevant to inflammation, so I'm going to erase it. Following the increased endothelial permeability, the leukocytes cross the vessel and arrive to the site of focus of inflammation. These leukocytes are mainly phagocytic, like macrophages, who eat up and just digest the offender. Or they can also be granulocytes to release granules full of potent chemicals. This results in the elimination of microbes or dead cells or whatever other offending agent that we have there, and therefore completing the third step. So far, the recognition of the injurious agent has been completed. The leukocytes have been recruited to the site of the inflammation, and the offending agent has been removed and eliminated. The next step is the regulation and termination of the response. Inflammatory response, if not.
Can somebody comment if they can have been seeing this video? You have been seeing the video? Okay,
Yes.
Larry's having a hard time with it, so I'm going to continue it, okay?
I can see it too.
Great, thank you.
Regulated can have harmful consequences and damage the tissue in the process of removing the offending agent. Most cells involved in inflammation have short half-lives and die by apoptosis within a few hours. The same goes for the mediators, which have short half-lives and decay quickly. There are also a number of signals that actively downregulate the inflammatory response. This happens mostly by a switch in the concentration of mediators from pro-inflammatory leukotrienes to anti-inflammatory lipoxins. So by this point, the regulation step is also completed. But what is the outcome of the initial inflammation? There are three major possibilities. First one is the perfect outcome, which is the complete resolution, leaving no mark behind, which is the case when the offense is not too extensive. The next possibility is healing by leaving a scar tissue or connective tissue behind. So this would involve production of cytokines and growth factors, recruiting fibroblasts to produce extracellular matrix proteins and cells. Another possibility would be the progression of the acute inflammation into a chronic inflammation. So this happens in the case of persistent injurious agent or interference with the healing process. And that concludes the 5 steps or the 5 R's of inflammation and brings us to different types of inflammation. So far, it's been made clear, I think, that we have 2 different types of inflammation. Firstly, acute inflammation, which is the initial rapid response to the injurious agent and lasts for minutes or hours. So it only has like a short duration. So it's also important to know that neutrophils are the major leukocytes involved in it. The second one would be chronic inflammation, which happens if the acute inflammation doesn't achieve its goal of eliminating the offender and instead progresses into a long-lasting chronic inflammation. Inflammation can also be categorized based on its location, so it can be local or systemic. Local inflammations happen in response to a local infection or injurious agent. Despite the fact that most of the response is limited to the local site of injury, local inflammation can also have systemic manifestations. So just think of fever in the case of a bacterial or viral pharyngitis. In rare cases, for example, disseminated bacterial infections, we would have systemic inflammatory reaction. This reaction is called sepsis. Thank you very much
Okay.
for watching this video. Don't forget to subscribe to the channel.
Okay. So that was kind of a broad overview of inflammation, and acute inflammation is different than chronic inflammation, and chronic inflammation is more of a long-term disease state that we would see with some of our patients who are older or have multiple comorbidities. But it's really the first line of defense in everything, right? So it was important to kind of understand inflammation. Inflammation just doesn't occur when you sprain your ankle. Inflammation is the first step in attempting to resolve the problem within the body and heal it. So that brings us into our NACT, low system resources. That brings us into our next piece here. And this is where I gathered information for our 30-day readmission statistics, or 30-day readmission top 10. And then I added a couple more because I think we're going to see them as community paramedics out there quite a bit. So this is a report or a division of the Department of Health and Human Services. And this is a report. It's hard to have up-to-date reports. So the earliest I could get was 2018, but it will continue to probably be synonymous with the main stuff that we're talking about, except COVID will start to probably take over some of the top rankings here during the 2020s and then 2021 timeframe. But we looked at the data going for 2018, and this was based on some insurance retrospective study on some insurance data, and they looked at 3.7 million hospital readmissions that occurred prior to 30 days. 30 days kind of the cardinal mark for insurance companies. If you can keep a patient out of the hospital 30 days from being admitted, then the likelihood of them being readmitted goes down substantially. Let me see here real quick. Oh, let me see here. Oh, yes, I can, Larry. There we go. Thank you, Larry. Larry's back with us. So we looked at 3.7 million of these readmissions, and I went through and took the top 10 and then realized that there was about 2 more that I wanted to include. So this is my top 10 plus 2 hospital readmission rates. So topping the chart is septicemia or sepsis. It seems like nobody gets discharged from the hospital anymore without having a little buddy that they take home with them. But that's not the real reason. Typically, they're admitted for sepsis. It's one of the leading reasons for admission into the hospital. And the sole reason is because they can provide IV antibiotics easily and monitor the patient with serial CBCs and blood tests, etc. So septicemia or whole body sepsis tops the chart. And then heart failure is number 2. There's a high incidence of readmission for CHF patients. Diabetes complications. You know, diabetics on the acute side go to the hospital because of, let's say, hypoglycemia, right? And those aren't admitted. on the admission side, the diabetics are in DKA, and they need to be fluid resuscitated and have their high sugars brought down. And so those folks are admitted. And then likely the diabetic has a lot of comorbidities, we call it, which preclude them from just being discharged 100% healthy, ready to go. And we'll go through those. COPD, another huge readmission. Chronic obstructive pulmonary disease, that can be emphysema or bronchitis. That does not talk about what I call the stiff lung disease illnesses like sarcoid or pulmonary fibrosis, things like that. Those people did not make the top 10 list. So this is all just obstructive disease states, respiratory wise. Pneumonia, acute renal failure. It used to be acute kidney injury. Now it's called acute renal failure, where a disease process comes in and reduces your ability to have your kidneys function well, and that causes a whole host of problems, and we'll go into it. Psychiatric made the top 10 at 7. Cardiac dysrhythmias. This is really atrial fibrillation, okay? Atrial fibrillation is the leading heart arrhythmia in the world. And, you know, for some people, AFib isn't a problem. For other people, AFib with RVR, or rapid ventricular response, is a problem. And so cardiac dysrhythmias, that's not the only reason it made the list. It was AFib. There's other ones, SVT, VTAC, short runs of VTAC, et cetera. But the reality is cardiac dysrhythmias is 8. Respiratory failure, respiratory arrest, we'll go through those, or cardiac arrest, I would say, and then the complications post-discharge from that. UTI was the number 10, and then coming in with the +2, I'm going to put in fluid imbalances, and that simply is electrolyte imbalances. And then skin infection and wounds. Those are really high readmission rates. And really 11 and 12 were super important, even though they didn't make the top 10. This is all stuff, guys, that we're gonna see when we're out in the community. And the mainstay of our chronic healthcare side of the business is going to be managing these types of patients and keeping them from being readmitted. Remember, I talked about that community paramedic. You can have a chronic side and an acute side. Chronic side, keeping them from going back in the hospital, right? Acute side, keeping them from going into the ER, which then could end up causing them to be admitted. But our goal is to take care of them outside of a healthcare facility for as long as possible. So what causes readmission? You know, why are these people supposedly having a plan when they get discharged from the hospital and it all falls apart? You know, what happened? I mean, they knew what medicines they needed to be on. They knew where they were going, you know what I mean? And it's much deeper than that. And you're going to see, and you see it every day on the streets. You know, some of the homes are very well able to care for individuals who are ill. And some homes are horribly inadequate to care for people. And I'm not talking about the house or the state of the house. I'm talking about the people who surround them, the ability to do things, the ability to have help, so on and so forth. But what causes these readmissions? So we have lack of proper home care. We just don't have anybody who can help the 80-year-old widowed man who doesn't want to burden anybody, right? We just have lack of proper home care. We have nobody following up on him. That's where we hopefully all will come in. We don't have a plan, or he's confused about the plan. Many people will sit in a doctor's appointment and nod their head and say that they completely understand. And when you leave them with a follow-up question to check if it's clear and if they have a good grasp of things, which I recommend everybody does as a community paramedic before they leave, they really can't dictate to you what it is they need to do. So that level of even understanding is at the lowest end of blooms. It's not even there. They can't even really tell you what it is you just talked about or even wrote down. And even if you write down stuff, they can't maybe even understand what you're writing down. So it's a real challenge. It's a real challenge, and we know it is. And that's why this program's been developed. Lack of follow-up care, whether it's at a doctor's office or having a community paramedic come in, or a home health aide, or a lack of follow-up from family members coming in even, okay? Medication errors. Yep, healthcare providers make mistakes, and it happens. And the reality is they might be sent out with a medication error. Something didn't get added, something didn't get called into the pharmacy. If it doesn't get called into the pharmacy, or if it doesn't get routed to the pharmacy, the patient never knows they need to take it because they rely on that phone call from, Ollie down at the pharmacy to let them know that their new medicine's available. With these big box drugstores, they don't, things fall through the cracks all the time, and you're like the least of their problems. Medication compliance. Are they able to navigate their pill burden on a daily basis? Some people need to take pills 3 times a day. Some people are confused by what type of pills they're on or why they're even taking them. Medication compliance is huge. Most folks know their pills by their shape, size, and color. And when you talk to them about, hey, are you taking your antibiotic? Oh, is that the little blue pill that's round? It might take us understanding what the pill shapes are and writing them down for them or something, right? So medication compliance or lack thereof is a tremendous reason for readmission. Nutrition deficiency, right? If they're not staying nutritionally sound, drinking the water, they could potentially regress, right? So they become weak. They become, bedbound, starts to atrophy muscles. And now it's a whole nother level of problems because they're so weak, they can't even get up, right? So nutrition deficiencies is a horrendous readmission problem. Falls post discharge, right? So they're falling at home. They're weak. They have no bedside commode. They don't have a proper bed. Some people have to continue to ascend or descend stairs, and no effort has been made to put, a bed down where people can be safe and not have to ascend or descend stairs. That's a problem. They fall, they break a hip. Now they're being readmitted for a different injury, or they create a skin tear and it becomes horribly infected. Now they can become septic. Transportation issues is a problem. People don't have the ability to get to follow-up appointments at their doctor or their specialists, right? Post-discharge infections, unfortunately, I joked about everybody comes home with a little buddy, but that happens. So a lot of times if you get discharged from the hospital, sometimes you can get a UTI, you can get a pneumonia, hospital-acquired pneumonia, you name it, you can get a post-discharge infection. And then there's others that are just, as equal to all of these, but, are substantial in that they would cause a patient to be readmitted. So this is a snapshot of what's leading our readmission rates. The hospital, so the ER, right? You go to the ER and they stabilize, and they either stabilize to a point where they feel they can discharge you, or they stabilize you to a point where they can have a hospitalist come down and admit you for continued care for whatever reasons. it's hard to get admitted to the hospital unless you're significantly sick. They aren't just accepting anybody because insurance won't pay. So then, you got the discharge side of it now, where they're in their hospital and being discharged. You think that they should be all tied up with a bow. They have a caseworker and all of this stuff that's going on. But as you can see here, this list tells us really why that's no longer working, okay? Or it really never has worked. And we're just seeing a heck of a lot more patients than we ever have before. And we have such a healthcare shortage in America that, we're needing to manage this in a lot different fashion. And that was the advent of the community paramedic, as being one piece of that puzzle to make it better. So let's talk about some definitions that are going to be on my slides today. Etiology, it's a medical term. The cause, set of causes, or manner of causation of a disease or condition. Okay, so etiology is it's what is causing it, what's the set or manner of the cause, right? Versus pathophysiology is what is the disordered physiological process associated with the disease or injury, okay? So one is, what's causing it or what could have caused it. And sometimes they're synonymous and sometimes they're not, right? So you're going to see etiology and pathophysiology as two distinct terms on my slides going forward, okay? Etiology can be the attribute, right? Or of the cause or the reason. But really, pathophysiology is the study or the process of the disordered physiological state that's causing the disease or the illness. Let me see, I've got 10 chats. Okay, everybody. Okay, sorry. Saw that up there and I want to make sure I wasn't missing anything. So let's talk a little bit about septicemia, and I've got some notes that I'll probably be referencing and stuff too. But septicemia is, defined as the life-threatening organ dysfunction due to a dysregulated host response from an infection, right? Well, geez, what does that mean? What it means is that there is a foreign invader or a pathogen that is causing dysregulation of an organ or a organ system, okay? So, the skin is an organ and we can have a little superficial infection of the skin, and that would be one thing. But septicemia is more than that. Septicemia is where the infection is starting to cause organs to become dysfunctional, right? So let's say that we have a infective pericarditis, right? So we have an infection of the fluid that surrounds the heart, okay? And that infection is now infiltrating and causing the cardiac tissue to become diseased. And so its strength of contractility goes down. But then also the infection is causing fluid to build around the heart and the pericardial sac, and it's causing mechanical obstruction now, and it's causing organ dysfunction. And that's really what septicemia is. Now, septicemia can be started by a diabetic foot wound that unfortunately doesn't get healed or doesn't get noticed because they can't feel it. And then it seeds bacteria into the blood. And that's where blood cultures come into play, right? We'll draw blood cultures to see if we can isolate any bacteria in the blood, right? We'll grow it out in an environment that's warm with plenty of nutrients and see if the bacteria grows out, and then identify what the bacteria is. The pathologist does that in the lab. But in our case, we're talking about, let's say, a diabetic foot wound that seeds the blood. And so we now have a full-blown septic response, and this blood's flowing through the cardiac tissue, it's flowing through the lungs, it's flowing through the kidneys, it's flowing to the extremities, you name it. And then all of a sudden, it starts to affect a lot of the organs, right? So it starts affecting the cardiac tissue, it starts affecting the kidneys. And so now you have a systemic infection, right? It's through the whole body. And sometimes the infection can become so overburdening that it can't be fixed. And unfortunately, people die. People die all the time from sepsis. And that's why now a lot of EMS agencies and a lot of emergency departments are creating a septic protocol or a sepsis protocol where, you know, they're hanging antibiotics, like broad spectrum, cover your butt antibiotics straight away. And they're not waiting for blood cultures to come back in 3 days. And they're aggressively treating it because they were having a lot of mortality as a result of the sepsis just becoming rampant and killing people. So key highlights: it's a rapid progress, generally non-specific. A lot of times we don't know what the bugs are originally. You know, we utilize blood cultures to help guide us, but also broad spectrum antibiotics get hung. And really, we all know septic shock is just a complete overburden of the body's organs, and supply can't meet demand, and then demand ends up causing us to die. Okay. The etiology on this, or the cause, is typically bacterial or fungal pathogens. I think we can make an argument that we've seen some issues with viruses. People do die from influenza, but usually, you know, in COVID, we still don't understand completely all about COVID, but influenza, for example, influenza really would create a issue in the lungs. And so there's an argument, is it a pulmonary only and not a true septicemia? I think we could make an argument that, you know, when you go into cardiac arrest secondary to the influenza, or, you know, the other viruses that are out there, that it was you know, septicemia causing organ shutdown. But for the most part, bacteria and fungal pathogens, and bacteria by far outweighs fungal, but we can make the argument about viruses. I was just thinking of West Nile. I mean, that has caused people debilitating organ dysfunction and death. So what's the pathophysiology of this? Again, it goes in and our immune system gets activated, inflammation occurs, our endothelium and coagulation system goes into effect to try and help stave off the infection. Basically, what transpired is inflammation and organ dysfunction. Okay. I'm going to have to kind of just clip through these. I'm going to try and keep things to the point, because we're going to bump up against our quit time, and I want to get through these for you. So heart failure number 2, right? The heart's not able to generate a cardiac output sufficient to meet the demands of the body, right? This is a growing health problem. We have a lot of people with CHF. We have a lot of issues with high readmission rates, obviously number 2. The clinical diagnosis is often shortness of breath that is either at rest, that's worst case, New York class 4, or you know, shortness of breath with ambulation, chest pain with ambulation, and exercise intolerance. And it doesn't have to be on the treadmill. When I say exercise intolerance, it's getting up from your chair and walking to the bathroom, right? And then, of course, peripheral edema, pulmonary edema. You can have heart failure with preserved ejection fraction, which means your ejection fraction is good. It's over, 50%, let's say, right? It's not that classic low ejection fraction, weak heart, barely able to get anything out volume-wise. Heart failure now is classified as heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. You just have to think of, let's say, like a cardiomyopathy, like a large heart, where it's still able to squeeze, but it's the ventricle is so big, it's just not getting out the force that it needs, versus reduced ejection fraction is part of the left ventricle is dead due to a heart attack, and it's hypokinetic, and it's barely moving, and it's only spitting out 30%, right? Heart failure with preserved ejection fraction typically is going to be a right-sided heart failure, okay? Atria is probably affected the most. Etiology, there's numerous reasons or causes, right? Coronary artery disease, acute myocardial infarction, hypertension, vascular disease, myocarditis, you name it. There's a lot of things that affect the heart. Alcoholism, idiopathic, we don't know what happened, right? A lot of people are having heart failure secondary to COVID, right? So there's numerous etiologies out there, right? And then, so our pathophysiology with this is that our cardiac tissue has remodeled, okay? And it's remodeled from what they call a hemodynamic state to a neurohormonal state, and the tissue is no longer functioning as a muscle as it once did. It's become dysregulated. It's not the same cardiac muscle that we read about, okay? And there's changes that occur to the muscle that make it weak, make it easily stretchable, and a lot of medicines that we'll go to when we go into cardiovascular disease will work to reduce the renin-angiotensin threshold, work on diuresis and preload. There's new medicines called Entresto and how those work, and beta blockers to help cardiac remodeling. You'll notice that there's a lot of CHF and post-MI patients that get put on metoprolol, and it's because it helps reduce that tissue remodeling, okay? And neurohormonal changes affect the tissue and make it different than it once was. That's just a really down and dirty explanation of that. We can get into more detail when we get into the cardiovascular stuff. Diabetes, we have DM1. So this is number 3. We have DM2, right? So DM1 is metabolic disorder, can't make insulin. DM2, progressive disorder of glycemic control, can be reduced insulin production in the pancreas, or it can be obesity, right? Insulin resistance. Okay. Key highlight here is that this is a cardiovascular risk equivalent. These people are set up to have strokes and heart attacks like no other. Oftentimes it's a lifestyle issue. It's a medication compliance issue. It affects our vascular and organs and nerves and in tremendous ways, right? So the 2 leading cause of renal failure in America is diabetes and hypertension, okay? If we could fix those 2 problems and get them better controlled, we'd probably have a significantly reduced incidence of chronic kidney disease, okay? So, numb feet, eyeballs that you can become blind through diabetic neuropathy. And so it's just a really debilitating disease, that high sugar state. So our etiology is going to be the cause, right? So DM1 is always going to be autoimmune destruction of beta cells in the pancreas. They just never have been able to be created. Diabetes 2 is just going to be insulin resistance and insulin deficiency, like I explained prior. Our pathophysiology is beta cell destruction or reduction in the pancreas. And again, we're going through these, and it's like, how are we going to treat these patients, you know, in the home, and what are we looking for? That's going to all come in the endocrine chapter, the cardiovascular chapter, the respiratory chapter here for COPD and stuff like that. I'm really just trying to hit on the patho and some of the ins and outs of some of these disease states. So COPD, another horrendous readmission and need for immediate assistance if you're exacerbating, right? So chronic obstructive pulmonary disease, you know, 70% of the time on our etiology, it's caused by smoking, okay? And then the rest is through idiopathic means, or like a alpha-1 antitrypsin disorder, or horrible work environment, prior work environment. Welders who never used respirators, who are just breathing all of that flux, mechanics with a lot of petroleum products, you name it. But anyway, the definition of COPD is our airflow limitation and the alveolar destruction, chronic bronchitis, and emphysema, right? So what we have is the inability to get air out well due to alveolar destruction, chronic bronchitis, and emphysema, right? So alveolar destruction really is synonymous with emphysema. That's where those little alveoli collapse, and that's where the gas exchange in the lungs. That is the capillary bed of the lungs, right? Arterial and venous blood cross at that site, okay? And then bronchitis is just the chronic mucus, inability to clear mucus, inability to get volume out in a second that's sufficient, and it leads to chronic cough, which leads to shortness of breath, which leads to pneumonia eventually, potentially, or just inability to breathe and oxygen desaturation. It's a progressive disease. It can be stopped in its tracks if you stop smoking. Smoking is the leading cause. Stopping smoking will never reverse the disease. It is simply not reversible. COPD patients are treated for symptom relief, okay? And I mean, we make it better for them, right? We give them bronchodilators, we give them inhaled steroids, we give them long-acting bronchodilators, and we give them antimuscarinics, which are basically anti-mucus secretion medications to help slow that down. So chronic inflammation. Our lungs are chronically inflamed. So when we learned about what chronic inflammation is, COPD is like the poster child for that, right? Central and peripheral airway gets remodeled. It affects all of the airways. It affects our end stage airway, the alveoli. It reduces the amount of those, which causes hypoxemia. And it causes all of this just chronic mucus production due to inflammation. We got pneumonia. Pneumonia is a leading cause of hospital readmission. One, because of antibiotic non-compliance. I'm going to tell you right now, if we get them stabilized in the hospital and they get discharged and they're not finishing their antibiotic regimen or being monitored closely, it can cause a readmission. Pneumonia also causes nutritional status and hydration status in pneumonia patients. They feel like crap, can cause them to get readmitted. So this is where that nutrition and that hydration status come into play. But pneumonia is inflammation of the lungs caused by a virus or a fungus or a bacteria. It creates consolidation and infiltrates, which is just infectious areas within the lung. That infectious area within the lung causes there to be no oxygen exchange. Therefore, shortness of breath occurs, and it has to be treated with an antibiotic, an antifungal, or with time when it comes to a virus, okay? Typically, the pneumonia is going to be described by the pathogen. A lot of times in the community, we'll hear it as HAP, hospital-acquired pneumonia, under our key highlights here. CAP, community-acquired pneumonia, okay? Fungal, okay? And, you know, basically strep strains of bacteria, Haemophilus influenza, just influenza A and B, okay, H1N1, COVID caused it, and then mycoplasma can also be a etiology, the top etiologies for pneumonia. Basically, pathophysiology, the pathogen overgrows in the lung parenchyma, and it overwhelms its host and its inability to clear it, and it just starts to spread and worsen, okay? And they talked about transudate and exudates. Remember, those exudates exit the cell, and it's debris and trash and all of the stuff that creates pus, okay? Remember, transudate is more of a low protein, right? And that would be more like a peripheral edema. It's just leaking fluid. Exudates is synonymous with like pus, purulent drainage. Acute kidney injury, also known as acute renal failure. So acute renal failure now is acute kidney injury. It's acute decline in the renal function, causing a rise in the serum creatinine or a fall in the urine output, right? So if you have no ability to clean the blood, the creatinine goes up. And remember, I said creatinine stands for crap. So crap in the blood. So you're going to learn about creatinine and GFR, which is a filtration rate, the function of the kidneys when you go over labs, right? But acute renal failure, or now acute kidney injury, are a result of a disease process, right? What happened? They were taking a medicine in too much quantity, and it caused them to go into acute kidney injury. The simplest way we can throw somebody into an acute kidney injury is over-diuresing them and dehydrating them. Another way is simply dehydrating them, okay? Hyponatremia can create an acute kidney injury, all right? And so there's a lot of things that can cause this. A lot of times it's a secondary effect of something else, and it will cause the patient to have to be readmitted because poor renal function really will shut down the entire body, okay? Like I said here in key highlights, is often associated with other etiologies. Typically corrected easily by stopping what's offending the body, stopping the medicine. Sometimes a short-term dialysis might be necessary, okay? You know, acute kidney injury can occur from a significant UTI that turns into a kidney infection, right? And the kidney's just not functioning. And it just causes everything to back up and build up. So the etiology or the causes would be pre-renal, intrinsic, or post-renal, right? So post-renal is an obstruction. Intrinsic is a problem with the kidneys. Pre-renal would be something outside of the renal system, such as, let's say, a medicine or something going on with a perfusion mismatch, and the blood flow is getting reduced to the kidneys, right? Because the kidneys receive everything that they need, nutrition-wise, and the stuff needing to be filtrated from the renal artery. And if there's something compromising the blood flow to the kidneys, then that would be considered a pre-renal etiology. And again, impaired renal perfusion, a tubular necrosis, or an obstruction would be our pathophysiology. Psychiatric's interesting. The definition is multiple depending on what we're talking about. Major depressive disorder is different from schizophrenia, is different from bipolar, is different from anxiety, you name it. But psych is going to be a high readmission rate. And so people who are being discharged, let's say, post-manic, post-suicide attempt, those patients really benefit from post-admission care, including, counseling, including psychiatry appointments, including medication compliance. That is the biggest thing. Our biggest need with the psychiatric patient is medication compliance. And when these patients are medicated and monitored for effectiveness and things get flagged if it's not working, they do good outpatient. A lot of times those things don't happen. Also in psychiatric would be addiction. Addiction gets kind of glossed over as far as psychiatric conditions. Addiction could be extreme alcohol intoxication, alcoholism, okay, hardcore drug use, whether it was a heroin overdose or methamphetamine use, cocaine use, whatever they were put in for, that would fall under, psychiatry, this addictive type psychiatric condition. And those folks need, good follow-up care, counseling, adherence to the program if they truly want the help. A lot of times, these folks don't truly want the help and they're a high readmission risk, right? So reduced psychiatry availability is a key highlight for us. We have psychiatrists that are booking 8, 9, 12 months out. We're broke with regard to psychiatry. In my personal opinion, psychiatrists work essentially 9 to 2 every day. There's probably a lot more capacity that they could do, but I think that these cases are so just taxing on them and they take such long times to work through. They're half an hour, 45, 1 hour appointments typically. It's not anything shorter than that. Our availability for psychiatry is really, really limited. That falls on primary care medicine 99% of the time to kind of pick up the pieces. Here in my office, we have an outlet to U of M where we can consult psychiatric doctors. So we'll consult psychiatry on treatment methods or resistance things that we're seeing that we need help with. But I can see this being a big part of the community paramedic checking on this clientele, because it is unfortunately difficult to treat, and all of the resources for them aren't as easy as everybody's making it sound like they are. Okay, so our etiologies we've went through, typically the pathophysiology is going to be serotonin and dopamine reduction in the brain. We don't know why that occurs, but we have methods of improving it. Trauma, okay, so sometimes head injuries can cause psychiatric issues, or physical or emotional PTSD type trauma, okay, genetics, age, environmental conditions, and many are simply unknown. Next on the list of our top 12 is cardiac dysrhythmias, okay? It's a disturbance in the rate of the cardiac muscle contraction, right? Our key highlights is we can have acute versus chronic, right? So we can have acute being SVT, or we can have chronic, which is just, hey, I've had AFib for all my life. I keep my rate under control. I'm on blood thinners and it's all good, right? But AFib is the most common. And bradycardia is also a dysrhythmia, and that is something that can come with age, in the ability to create baroreceptor in our lungs. So the vagus nerve, can be stimulated through pressure changes in our chest, such as simply sitting on the toilet and trying to get out a constipated poop. And all of that pressure changes up in our chest, and it stimulates these vagus nerves, and it causes us to become bradycardic. And then folks fall off the toilet and hit their head. And if they're on blood thinners, let's say, you got to worry about a bleed, or they have they have osteoporosis, and they get a wedge compression fracture of their back. So dysrhythmias, can cause hospital readmission rates for a variety of reasons. And we have acute versus chronic. So somebody gets out of the hospital after having new onset AFib, they got them on blood thinners, the metoprolol might not be at the right dose, they break through, and their rate's out of control. The biggest thing with AFib is rate control. And so we need to get that rate control down. The community paramedic comes in, says, I'm having these heart palpitations again. It feels like my heart rate's going 120 miles an hour. And you check them out, and, their metoprolol simply needs to be increased. And if we didn't do it, it might lead to shortness of breath. It might lead to, pulmonary congestion. And so dizziness and falls. And so that's where we come in there. So etiology can be caused by cardiac and non-cardiac disease states. It depends on the arrhythmia for the pathophysiology, but AFib is caused by an irritated atrial tissue causing electrical reentry. So you just got that atria, just that SA node causing all of that reentry, and then the ventricle is just kind of doing its own thing until it starts to become rapid because it's trying to keep up with the ventricles. Respiratory failure. We had a lot of respiratory failure issues with COVID. We have a lot of respiratory failure issues with COPD. We have a lot of respiratory failure issues with really significant bilateral pneumonias in a patient with a lot of morbidities. But it's the acute impairment of gas exchange between the lungs and the blood. You're just not oxygenating the blood, okay? And it causes hypoxia. And that can be hypoxia with or without hypercapnia, right? So I'll talk about that in just a second. The chelates, it can be acute or chronic. Our etiologies are going to be asthma, chronic lung disease states like COPD, emphysema, acute respiratory distress syndrome, ARDS, due to a bacterial or viral illness. ARDS isn't ARDS because ARDS just comes up. It's actually a result of something, and ARDS would be, like a pneumonia, malignancy, a pulmonary embolism, clots, a spinal injury, not causing the diaphragm to function, you name it, right? But our pathophysiology is gas exchange falls below the metabolic demand, and a ventilation perfusion mismatch occurs, which results in cellular anoxia, and then typically tissue death or tissue asphyxia, right? So really, respiratory failure leads to death pretty quickly when we can't oxygenate any of our organ systems all at once, right? It's just horrible. So you could put people on a ventilator to mechanically ventilate them. So you can have hypoxia without hypercapnia. And what that means is if you stop breathing in a heroin overdose state, your CO2 just rises, right? You have a hypercapnia, okay? And as soon as you start ventilating the patient, that CO2 can come down. Well, in a, let's say like a PE state that causes respiratory failure, you will still be able to exchange gas at the capillary level, and you will not have hypercapnia per se, because it's not a lung issue, it's a blood supply issue. Now, if you have, you know, a massive pulmonary embolism that results in, you know, no blood flowing for whatever reason, that's going to be cardiac arrest. And, you know, of course, that would lead to hypercapnia. But that's kind of what they're getting at when they say hypoxia, so low oxygen with or without high CO2. UTIs are a leading cause of hospital readmissions, right? So it's an infection of the kidneys, the bladder, or the urethra, right? So the kidneys spill their content into the ureters. There's a ureter on the right, a ureter on the left. They kind of trickle down and fill the balloon, which is the bladder. And then the bladder has a urethra that excretes the urine out to the toilet. And basically a UTI, a urinary tract infection, is synonymous for kidneys, bladder, or urethra infections, right? We have three types. We have infectious cystitis, which is the most common. That's simply a bladder infection, right? A urethral infection, and that's our typical, I have a UTI type symptom, okay? Pyelonephritis is where things transcend up the ureters into one or both kidneys. So the bacteria starts to seed into the kidneys, and that's a more septic type state. That's where things start to go really poorly quickly, and you know, the kidneys start shutting down, and infection and fever and antibiotics are needed straight away. Okay, and then you know, if the urethra is infected solely, you get that urethritis, and that is, you know, the burning when you pee and stuff like that. So that gets inflamed. So typically infectious cystitis is the most, which is the bladder, and then it actually will be urethritis is second, because it just all is connected there. Pyelonephritis is somewhat rare, not super rare, but it's not like every 10 cases that come in that has a UTI. I'm worried about pyelo. Okay, pyelo is the type of kidney issue that happens with the elderly who just disregard everything and don't really pay attention to the pain or the reduced urine flow or things like that. In fact, they're happy that they're not peeing, and then it turns into a raging pyelonephritis or kidney infection. So E. coli, 70% of the time, E. coli, we have a wide range of antibiotics that can handle E. coli. We start off with basic ones first, and then progress up as necessary. I always get a culture and sensitivity on my urines to make sure I'm treating with the right antibiotic, because bacteria can be a little bit different from case to case. Staph infections, excuse me, are 20% of the causes. Both of those respond well to broad spectrum antibiotics. Bladder infections can be a form of septicemia. We call it urosepsis. We can see the blood and then get a raging systemic infection. Our patho is bacteria colonization in the genitalia, ascends up the urethra and into the bladder. Bladder stasis, or the inability to clear our bladder on a regular basis, results in our body's diminished ability to fight and defend from UTIs. And you know, that's kind of how it gets started. And then the pyelo gets started by it transcending up the ureters. So we have a lot of people who will get UTIs who hold their urine all the time, right? Holding. And that gets into that whole bladder stasis issue where we're not able to clear our bladder. Like I said, old people don't like getting up and going to the bathroom. One, because they think they pee too much as it is. And then two, because they might not be stable enough to do that. Fluid imbalance, electrolyte dehydrations, hyper or hypoelectrolyte disorders. So hyponatremia, hyperkalemia, hypokalemia, you name it, fluid imbalances. There's typically an underlying cause that needs to be corrected here. Medications can cause potassium and sodium deficiencies. Fluid consumption can alter sodium, nutrition, disease states, diabetes insipidus, CHF, and renal failure all can contribute to fluid imbalances. Cellular dysfunction occurs due to lack of the cat or anions, creating then organ malfunctions, right? So if we have cellular, it affects the tissue, affects the organs. And so then we have issues with, the cardiac muscle being hyper sensitive because of potassium disorders or calcium disorders, right? So if we're having any fluid imbalances, when I say fluid imbalances, it can be simply water, it can be electrolytes, right? I'm talking about all of that, and you're going to learn about these when you go through the labs, but fluid imbalance is a real reason we have readmission. So if somebody gets sent to the ER because they felt like crap and their potassium was 2, and we give them a bunch of potassium and then we send them home, well, we got to make sure that we are checking that potassium and adjusting up the potassium accordingly, or addressing why we're getting low potassium. Well, they might have low potassium because they still got that bottle of Lasix there that they were told to stop 3 months ago and they haven't been, right? So then skin and wounds is number 12. Skin and wounds is a breeding ground for infection. It's a disruption of the skin resulting in skin compromise. Remember, skin is our largest organ. It needs to remain healthy because it's our barrier. As soon as we start stretching our legs because of edema, it opens up pores, which is able to allow bacteria to pass into our body more readily. That's the leading cause of like a leg cellulitis. It is swollen legs. It's an infection that might need antibiotics. We might need, mechanical wounds will need offloading. Inflammation needs to be controlled, and it's a large metabolic demand on the body, right? So nutrition and fluid status is uber important in these patients, right? So really what these key highlights was saying, infections need antibiotics, things that are mechanical like a pressure bed sore needs to be offloaded, inflammation needs to be controlled, and we need to keep them nutritionally sound with protein and hydration. Our etiologies are trauma, disease, and pressure. And our pathophysiology is hemostasis, right? Okay, so lack of blood flow or slow blood flow to the area, like the diabetic that's got the bad small diseased blood vessels in the feet. Inflammation, proliferation of the wound and bacteria, and then maturation, which would be resolution. So really what I'm talking about here with the pathophysiology is the wound healing. The first phase is hemostasis. We need to stop the bleeding. Inflammation then needs to come in and start the inflammation process to clean up the damaged area. Proliferation is the growing of the new skin tissue, right? The granular tissue. And then maturation occurs at about 3 months when 80% of the wound is healed. And that's if it heals, right? Sometimes it takes a lot. It takes wound vacs, mechanical debridement, continuing to cut away all of that tissue. And that all happens during this inflammatory phase of healing. So I got a little mixed up there. I talked about what causes the wounds to maybe not heal, as opposed to these stages that I wanted to kind of highlight for you today. So going back, both of them are right, but I wanted to clarify that. Okay, so it's 10:52. And we're not going to talk about cultural competence, okay? So if everybody can just turn on their cameras. I just want to make sure everybody's still with us. It's always nice to see faces. Thank you. Does anybody have questions? Can anybody give me feedback? Was this on par with what you were expecting today?
I just gotta go back and write more detailed notes with it. So it was
Yeah.
helpful.
Okay. I'll put these up for you on Moodle, okay? As far as the cultural competence, I think it's just looking, there's a lot to it, right? There's bias training now that's going on. Just go through and understand that, we need to look within, okay? Understand maybe what some of our biases are and work to acknowledge those and not let them interfere with our care to others. We want to also, talk about the DIE model, where we want to describe in our terms what we're seeing, interpret it, and evaluate it before we come to any decisions on things. There's 4 dimensions of culture: individualism, the power, masculinity, and conflict styles. And I think that the book did a good job of outlining those. I read that chapter, and it did a really good job of outlining those. And it might just give you the insight that you need when you're dealing with some folks in their home. And I think one piece of advice that I can just give you is that be a member on their team, right? When I talk to a patient, I let them know that I am here for them, that they are completely in charge, and that I am going to make recommendations, but I am open to discussing them, and we can come to terms with whatever they feel the most comfortable with. And I think that that really goes a long way with patients feeling comfortable about what it is you're trying to do. Maybe in our case, why we're in their home trying to help them. And it allows them to feel a sense of control. And a lot of times when we deal with some of our older folks, which is really going to probably be a lot, we're going to be dealing with an older population as community paramedics, maybe not completely, but the majority of it. They want to know that they're taken care of, they're being listened to, and they're not being taken advantage of. And so that's really kind of some of the big fears that these older folks have. And with that, I'm going to wrap it up, and I'm going to turn it back over to Larry. And I will see everybody back on the 7th, which is what, next Tuesday, I think. Next Tuesday.
Yes.
Yep.
Okay. Next Tuesday, and same time, same place. And we're going to talk about a lot of different stuff. We're going to be talking about patient assessment, and that'll be some cool stuff. And we'll bust it down with what the book says, and then what I think would be beneficial for you as well. Okay. And I'll look and see what chapter 9 and 10 are. And of course, I'm only going to hit, your time is valuable. I'm only going to hit on the stuff that I think is going to be the most beneficial for y'all. Okay.
Okay.
So in this advanced healthcare education that you're all embarking on, there's a lot of self-learning that has to occur. That was one thing that I found when I went to PA school, is that, there's a lot of stuff that you think we might be going over. And if we don't, it's really going to fall on us to go back and study it and work to understand it. And Larry and I are here to help you with whatever you need. Just reach out to me via my email and we can set up a time to talk. But with this advanced healthcare type education, there's too much information to be given in any single lecture. And so I'm always going to go with what I think is going to be the most beneficial for you. But that doesn't mean it might not be on your test. Okay. Larry, that's all I got, buddy.
All right. Thank you, Patrick.
You're welcome. Have a great weekend. I hope everybody stays warm. I'm going to go get into clinic now. So I'm going to sign off and I'm going to let Larry take over. Okay. Do I need to get out of this? Larry, stop sharing.
Yep, what you just did.
Cool. And then I am going to let you take over and I'm just going to end. Okay, bud?
Sounds good. Thank you.
Bye, everybody. Have a great weekend. Okay. Thanks for being here and listening. I appreciate it.
All right, ladies, any questions from you? No? Okay, if you haven't noticed, as I move my camera around, as I move around my office, I did a lot of revamping on Moodle. It lines up much better with the success plan. Hopefully the quizzes that didn't have or whatever questions, I have found those. If not, don't panic. Somehow let me know. Because sometimes I see them and you didn't. And I'm like, why? But anyways, let me know. With such a small class, which makes this really nice, is we have the ability to, instead of holding hard and fast to deadlines, on quizzes and that, if something, if it's my mistake, it's my mistake. I can't hold you responsible for that. And I won't hold you responsible for that. We just work through it. There's, this is a whole lot different than a class of 24, where it's going to be really down and, hold tight. So if you guys have no questions, we'll end this. You can go back, have fun doing whatever you're doing. Again, if Teams is up and you have questions, ask. You got the email. Otherwise, we will talk to you all later. Have an awesome week.